All right, welcome everybody. It's my pleasure to introduce to you Dr. Samuel Johnston, who's going to be talking about ambulatory ECG monitoring today. Dr. Johnston is an Iowa native. He grew up in Ames and then came to the University of Iowa for his undergraduate degree in biochemistry. And then with the exception of a 2-year fellowship at the NIH in Bethesda, he's completed all of his medical training in Chicago before coming back here to join us at the University of Iowa. He's board certified in cardiovascular medicine and clinical cardiac electrophysiology and is an assistant clinical professor in the Department of Internal Medicine here at the university. And with that, I welcome you and look forward to your talk.
Thank you, Dr. Zingman. Welcome, everybody. Today, we'll be talking about ambulatory ECG monitoring. And what you're seeing here is a picture of its inventor. This is Norman Jeffress Holter. He went just by Jeff Holter. And he was not a physician, but had master's degrees in physics and chemistry and was ultimately a full professor at University of California, San Diego. I have nothing to disclose relevant to this talk. The objectives for today's talk will be to understand when to order ambulatory ECG monitoring in your patients with suspected cardiac arrhythmias, to describe the differences between the traditional Holter monitor, the extended recording Holter monitors that are available nowadays, like the ZOLL patch, and as well as event monitors and ambulatory telemetry monitoring and implantable loop recorders. I'll also describe some of the newer home health options for heart rhythm monitoring, like smartphones and smartwatches and a couple of other things. And hopefully you'll learn something about how to choose the most appropriate monitor for your patient's circumstances. And we'll also learn by reviewing real patient cases. The way I've organized the talk is that we'll start off by talking about the different types of monitors. Then we'll look at some interesting cases of real patients. And we'll finish by talking about the future of ambulatory ECG monitoring, which I believe will be largely performed with smartwatches and smartphones and other direct-to-consumer devices. And that's already starting to happen. So we'll talk about that. Starting just with the basics, the Holter monitor, as you probably know, monitors a patient for 24 to 48 hours. It collects all of the ECG data during that period of time. The patient keeps a diary of symptoms, and the patient returns the monitor to the technician, and the technician scans it, and the physician interprets the data and makes a report. So this is our traditional Holter monitor that most of us are used to. If you're not, you're going to become familiar with it in a moment. The exception to this is that, sometimes some places are using Holters that are a patch, and we'll talk about those separately. This is an example of a Holter monitor from 1976. I thought it was kind of interesting. You can see it has a little digital display on it, and I'm sure it was considered very high tech and solid state for that time. And nowadays, Holter monitors look more like this, at least the traditional Holter monitor does. It attaches to the patient with 3 to 5 ECG leads, and then the patient wears a little monitor on the belt. And it creates a recording that looks something like this. This is an example of a report that gets generated automatically. This is before the physician adds any interpretation. Ordinarily, can you see my arrow, anyone, up here on the indication?
Yes, we can see it.
Okay, thanks. I think it's very useful when looking at the report to know why it was ordered. That's not listed here, but usually it would be. We can see that when this test was performed and the duration of the test, we can see that this patient had about 100,000 QRS complexes in a 24-hour period, which is typical for most adults. We can see ventricular ectopy here, and we can see supraventricular ectopy over here. We can see that there were no long pauses here, and we can see the minimum heart rate, the mean heart rate, and the maximum heart rate. And these, and the minimum and maximum, the times are given. This is useful because a lot of people have relatively slow heart rates at some point when they're asleep. Here we see the trend of the heart rate displayed graphically, and it's pretty clear that the patient probably fell asleep around this time, around maybe 10:15 p.m. and slept relatively soundly, and probably had an alarm clock that went off at 5:30 in the morning. Beyond this, we see individual tracings that are just ECG strips that the technician picks out for us that are of interest. Like they might be an ECG strip that corresponds to the time that the patient had a symptom. And that's also in the report. And I think it's useful for everyone to look at that stuff, especially whoever ordered it, you know, if it's primary care office or cardiology office or wherever it's coming from. A couple of Holter monitor result pearls I want to list here are that it's common to see some supraventricular ectopy in almost all adult patients. And we can see as many as 3 to 5% supraventricular ectopy occurring as frequent PACs, couplets, or short runs of atrial tachycardia in patients that are elderly, patients that are obese, and also patients that consume a lot of alcohol. So a lot of times somebody orders a Holter monitor and then they get back a report that says the patient's having supraventricular tachycardia. And I list this just because it's helpful to know that these types of supraventricular ectopy and SVT are common in these groups of patients, and it's to be expected, an expected finding. Also, Holters are often ordered to check the burden of PVCs, knowing that a lot of PVCs can cause a cardiomyopathy, and vice versa. We all know that cardiomyopathies also result in patients having PVCs, but I just like to point out that it's uncommon for a cardiomyopathy to occur due to PVCs when the patient's having less than 15 to 20%. Usually they're having more than 20% when they develop a cardiomyopathy. And that ablation of monomorphic PVCs is indicated when the patient is symptomatic or has a cardiomyopathy. It's also, I think, very useful to look at the diary. Lots of times one of these tests is ordered for palpitations, and the patient might indicate, you know, several instances of feeling palpitations, and these all correspond to sinus rhythm with no ectopy, and yet the patient has an overall burden of PVCs of 6% or 10% or something. That's relevant because the patient's palpitations may be non-cardiac, and by looking at the diary, that's really the only way to know what's going on. Just like the patient's, any other part of the patient's history, I think knowing the diary is perhaps the most important thing you can get. Second generation Holter monitors, or maybe they're, you know, it's more than second generation, but the latest iteration of Holter is to put on a patch. And the first one that was introduced by a company called iRhythm, and they call it a ZO patch, even though it looks like Zio patch, they say ZO. And this came out in 2010. And it has evolved since then to be a little bit smaller and a little bit more reliable. And there are at least 2 other competing companies that offer the same sort of technology now. This is pretty handy because it gets applied to the skin and it just stays on the skin for up to 2 weeks, and the patient can shower with it. And there's a button right on the on the top. This part of the device where it says ZO is actually a button, and whenever the patient has symptoms, he or she can push that to mark the time so that that can be correlated with the underlying heart rhythm. Also, they're disposable, so if you have a patient that may be unreliable and maybe you're worried about never seeing your Holter monitor again, it's okay with these things because they are disposable. If it never comes back to you and it gets lost, it's not that expensive. So it's also very useful, I think, in emergency room settings where they may not see the patient ever again. The traditional event monitor records up to 30 days and is different from the Holter monitors. It has 2 types of triggers. There's a patient triggered response where the patient presses a button and activates the monitor when he or she is having symptoms so that we have a recording of what was going on at that time. And there are also auto triggers. So the modern event monitor has both of these features. Auto triggers mean that the device records some predefined abnormality, and they can be set up however you want depending on what you're looking for and what the patient's age is. But typical out-of-box settings would be like a pause of greater than 3 seconds would get automatically recorded by the device, a heart rate of less than 40 beats per minute for at least 4 seconds, a heart rate greater than 150 beats per minute might be an out-of-box setting, or an irregular rhythm that is suggestive of atrial fibrillation would get picked up by the auto trigger. These devices send data via a handheld device to a central monitoring station, and then the physicians are notified by technicians at the monitoring station if an arrhythmia is detected. The cumulative data are interpreted and reported by a physician at the end of the monitoring period. So when you order a test like this, it usually takes a couple of days to have it put on. It takes 30 days to have the whole thing. The recording period takes 30 days, and then it can take another 2 weeks to get the full report back. So you're looking at probably at a minimum 6 weeks from the time you order the test to the time that you get the report. And this is what a common contemporary event monitor looks like. It looks very similar to a Holter monitor, and in fact, in some cases, the same device. In this case, this particular device can be reconfigured to function as a 24-hour Holter monitor, or it can work as a 30-day event monitor, but it does one or the other. Implantable loop recorders are an option for longer-term monitoring. The 4 that are on the market now, I've shown here. There's Medtronic makes one called the Reveal. Boston Scientific makes a similar model called the Lux DX, and St. Jude or Abbott now makes a similar device called the Confirm RX, and Biotronic makes a larger monitor that they call the BioMonitor 3. These things continuously monitor a looped cardiac rhythm, so they don't gather and store all QRS complexes. They only keep relevant auto-triggered events or patient-triggered events, and then they discard the rest of the information. They have pretty good dedicated algorithms for AFib detection. The battery life on these nowadays is between 2 to 5 years, probably averaging 3 years. The data here are, like Holters and event monitors, physician facing. That is, the physician gets the data back, the patient does not. And that's worth pointing out because the newer devices, the Smartwatches and and smartphones and other options are the data are patient facing. So we'll talk about the advantages and disadvantages of that a little later. These devices are fairly expensive. They often cost the hospital about $4,000 to purchase this device, and then there's additional expense for implanting them. So it's an expensive option, but they're good at monitoring patients over an extended period of time for an arrhythmia. This is sort of the evolution of these implantable cardiac monitors. I thought having this perspective is kind of interesting. These things were first dreamed up in 1990, and then the very first one came out in 1995. It essentially was a pacemaker with a lead, but it didn't have the ability to pace the patient. It could only make recordings. And then the first subcutaneous implanted devices came out in 1998, and they I guess with the exception of the Biotronic monitor, they've become progressively smaller, and now they're injectable. And so they can be put in quite easily. Some offices, I think, put them in their clinic, and some places still put them in an EP lab or cath lab. So how to choose the correct monitor. So looking at Holter monitors, since this works is placed for 1 to 2 days, or the patient needs to have daily symptoms. If the patient's not having daily symptoms, don't order a Holter monitor. The Holter monitor is best for patients that you can be pretty certain that they're going to have an event on the day that you put it on. An event monitor it can record for up to 30 days, so it's important to know that the patient has symptoms or some event at least once a month. Otherwise, you're unlikely to capture it with the event monitor. The implantable loop recorder can last for 2 to 5 years, and this is useful for a patient who has infrequent symptoms. And if you're looking, depending on what you're looking for, AFib or stroke, or AFib or syncope or something, you can get diagnostic info in about 90% of patients after 1 year. So that makes it actually cost effective when compared to ordering multiple Holter exams or multiple event monitors. But as we'll discuss a little bit more later, insurance companies don't want to pay for implantable loop recorders anymore under most circumstances. So sometimes you're forced to get a number of event monitors before you can get an implantable loop recorder, or maybe you can never get an implantable loop recorder. But there are other options available now through smartwatches and things that, again, we'll be talking about. This is a graphic that I think is useful, and it reminds me that when I'm talking to a patient about their heart monitoring option, I remind them that their ECG that they have when they come into clinic is really only 10 seconds of their life. And that's analogous to a single frame in a movie. And depending on the type of movie, maybe you can tell that it's a light romantic comedy, and maybe you can tell that it's a horror movie, but lots of times you can't figure that out just from 10 seconds or a single frame from a movie. So if you can see an entire scene, maybe with a Holter monitor and an event monitor, you can get a pretty good idea of what's going on, what the theme is. But when you need to see the whole movie, that's when you put in the loop recorder, and you can get this. This is an outdated slide. It says up to 36 months. Really, we can get up to 5 years probably with some of the newer monitors. So when choosing the correct monitor, again, the Holter monitor records for only 1 to 2 days. So we want them to have symptoms every day. The sort of symptoms that would be appropriate to look at would be things like palpitations, near syncope or syncope, dizziness, lightheadedness, sometimes chest pain or dyspnea or fatigue. But it's worth mentioning that the more common causes of chest pain and dyspnea should be worked up before ordering a Holter monitor. I have one physician that has ordered 3 Holter monitors that I've interpreted in the last year for dyspnea on exertion. And I noticed that the patient never had a stress test, and he has a lot of risk factors for coronary artery disease. So I think this is not your primary, your first line test, obviously, for chest pain or dyspnea, but it can be useful in some patients. The sort of diagnoses that Holter is good at making are AFib or aflutter, supraventricular tachycardias, PACs, which may be symptomatic, inappropriate sinus tachycardia, especially in younger patients, sick sinus syndrome, especially in older patients, or heart block, or frequent PVCs that may be symptomatic or may be asymptomatic, or they may be asymptomatic but causing a cardiomyopathy. Ventricular tachycardia can be detected, and very importantly, non-cardiac symptoms can be diagnosed. So a patient may come in with a Holter monitor, have very severe symptoms of palpitations 10 times during the day that he or she wore it, and then those all corresponded to normal sinus rhythm. Then you can be relatively certain that the patient's symptoms are not related to his or her heart rhythm. And in terms of following patients with a known arrhythmia and their management, Holter monitors are good for quantifying heart rate. So if you have a patient with permanent AFib and you're wondering what their average heart rate is, or whether they're having long pauses, a Holter monitor is useful to assess your therapy. Maybe you want to titrate up your metoprolol or your diltiazem, or maybe you want to reduce the dose. It's helpful in assessing patients with sick sinus syndrome and inappropriate sinus tachycardia. And again, as I said, quantifying PVC burden. A 30-day event monitor is useful in establishing a diagnosis in patients who have symptoms or events that occur at least every month. And again, the same sort of symptoms: palpitations, syncope, dizziness, chest pain, dyspnea, and fatigue. The potential diagnoses are the same. You may pick up AFib or flutter or SVT or these other diagnoses. They can be useful for arrhythmia management. So perhaps you think you've effectively treated their AFib or aflutter by performing an ablation or putting the patient on an antiarrhythmic drug. A 30-day event monitor gives you a little more perspective than a Holter monitor, and so you can feel better knowing that you didn't see any AFib over a 30-day period than you could over, say, 1 or 2 days. Also, if you've stopped an antiarrhythmic medicine, or you lowered, for instance, their metoprolol, and you wanted to see if they were still having long pauses, it would be nice to have the perspective of a month rather than just a day, and knowing that they're not having pauses. Likewise, you just have a longer time to detect things like SVT or PVCs. For implantable loop recorders, they are useful for making a diagnosis in patients with cryptogenic stroke. That's a common indication for them. Perhaps the patient has risk factors for AFib and has had a stroke, but there's no diagnosis of AFib. So you're not anticoagulating, but you think maybe you should. And of course, you shouldn't unless you have the diagnosis. So diagnosing atrial fibrillation in and of itself, or monitoring a patient's burden of atrial fibrillation, can be effectively accomplished by implanting an ILR. They're also very useful in figuring out cause of syncope, whether it's sick sinus syndrome, some transient AV block, or a ventricular arrhythmia. And also, by process of elimination, they tend to be useful in establishing a diagnosis of seizure, where a patient's been previously diagnosed with syncope, but they have several events, and during those events, they have witnessed loss of consciousness or some something that may look like a seizure or maybe not classically a seizure, but you can at least know that in some of these patients, the rhythm was normal at the time that that occurred, and that it was not caused by a heart rhythm abnormality. And for monitoring patients with known arrhythmia, monitoring AFib burden can be effectively accomplished with a loop recorder, although getting reimbursement for that would be almost impossible nowadays. I put this Holter monitor in here to remind me to tell you that if you have a patient that has syncope or high risk features of syncope, or you have a gut feeling about that something is seriously wrong, then don't put on a Holter monitor or an event monitor. This is an example, a real example where a patient had a Holter monitor placed, and you can see at 6:02 in the morning, he was in normal rhythm, and he went into VT or VF, and it degenerated. And by 6:11, he was asystolic, and of course, this patient did not survive. In these cases, I think that a wearable Cardioverter-Defibrillator can be used, and I have Dr. Zingman didn't know she was going to make a cameo appearance here, but I found this picture of Dr. Zingman demonstrating a ZOLL life vest. And so this is something that you may or may not have seen, but in addition to being an external defibrillator, it's a really good cardiac monitor for patients who are high risk for sudden cardiac death. Here's a mannequin wearing one of these devices so that you can see the vest on the torso, and then you can see there's a little waist belt with the device itself and the battery pack. And this is just the whole thing displayed on the counter. This is a patient that I saw, I think in 2018 at an outside hospital. She's 53, athletic woman who was kayaking with her daughter, and she had recurrent syncope while they were kayaking. And the history really scared me. And she came in to this hospital, and she had a normal echocardiogram, and she had a normal angiogram, and she had a slightly prolonged QT interval once, but the rest of the time it was all normal. And I wanted to either get a cardiac MRI and or do an EP study. And these were not available at this hospital, but the woman felt fine and she looked good, and I couldn't get those tests scheduled really quickly, and she had a wedding that she wanted to attend in Kansas City. So I placed I was afraid to let her go, but she seemed too healthy to stay in the hospital. So in this instance, I put on a wearable Cardioverter-Defibrillator or life vest. And this tracing here of her ventricular tachycardia at 300 beats per minute was recorded at that wedding in Kansas City. It saved her life. And then she later came to the University of Iowa, where she had a cardiac MRI, and it was found that she did have a cardiomyopathy that was just sort of occult. This is the order form for a ZOLL life vest, and I just want to highlight here that there are very specific reasons that one can order this for, and so it's not that easy to order a life vest for anyone for general monitoring because they're expensive. But if the patient meets one of these criteria, then you can use it, and I think it's just worth mentioning because people don't often think of them when they think about cardiac monitoring, but they deliver really nice tracings, as you can see here. Here are some other examples of interesting tracings. I already showed you this patient. This is an interesting tracing that hopefully you never see. Here is a patient that you can see on their monitor. You can see QRS complexes probably sinus rhythm or sinus tachycardia here. And then all of a sudden, you don't see the QRS complexes anymore. This is an example of a patient who had transient complete heart block. In this case, it was due to a vasovagal cause. But this was useful to have that. This is a little concerning. This is a patient who is having torsade on the monitor, and I believe this was due to a reversible cause, so this was very useful to know this. Here's another example of torsade. It's not obviously torsade here, but you can see in this other example on the same patient that they have a long and then a short interval before it starts up, and the patient had a very long QT interval. This patient conveniently came to the emergency room before having this rhythm. Here's a Holter monitor from one of my patients. This is 8:06 in the morning, and this patient is in normal sinus rhythm here. You can see a P wave and a QRS and a T and the same thing over and over again, and then you see a PVC, and then you see a narrow complex tachycardia that's regular, and it ends on its own. And then at 10:35 the same morning, the patient does the same thing again. A normal rhythm, PVC, goes into this rhythm, regular narrow complex tachycardia, and it is self-limited again. And patient's having a bad morning, 11:52, same day, PVC, same thing, SVT. And so the same PVC here comes in and it conducts up the retrograde fast pathway while the native sinus P wave is traveling towards the AV node. And the native P wave must travel antegrade down the slow pathway, which initiates this rhythm, which is a typical slow, fast AV NRT or atrioventricular nodal reentrant tachycardia. And for all of the closet heart rhythm nerds out there today, this is an example of concealed conduction. Here's an example from an implantable loop recorder. Here we see, this is just the printout that we get during a regular interrogation. We can see that it was implanted in 2019 because the patient was having palpitations. We can see the battery status is okay. And over the last month, we can see that the device recorded 2 pauses, but the patient didn't have any symptoms of palpitations during this time. We just incidentally see auto triggers for 2 pauses or 3 pauses, as it turns out. So down here, you can see one of these pauses. We can see a QRS and a QRS and a QRS here and here, and then we see nothing. Oftentimes on loop recorders, you can only see a QRS. Sometimes you can see the P wave as well. So when we look at the same patient and we look at this report, we see that there were 3 pauses, and the first one occurred at 2:51 a.m. It was for 3 seconds, and somehow in that vicinity, the patient, it recorded a ventricular rate of 300 beats per minute, which seems kind of weird and or scary. And then on July 13th at 6:34 a.m., the patient had a 3-second pause, and the ventricular rate around that time had been 59 beats per minute. And here on July 10th, the patient had, at just 1 minute after midnight, had another 3-second pause, and the heart and the ventricular rate around that time had been 188 beats per minute. So we look at it a little bit more closely. Here's the tracing. So this shows 2 problems here. One is this high frequency signal right here is noise, and it was recorded as ventricular fibrillation. You can see here, this is obviously not a physiologic signal. This was not the patient's heart rhythm. This is probably due to some movement of the device within the patient's body. It might be moving around, or maybe it's due to some external electromagnetic interference. But anyway, this is not physiologic. The patient's heart rate was not 300 beats per minute here. And then it says there's a pause, but yet we see QRS complexes coming through here, here, and here. So This is an example of undersensing right here, where the device incorrectly labeled it as a pause, and this is oversensing due to artifact or noise in the beginning of the tracing. And this is a common problem with loop recorders. Here we see a similar example. This is a different patient who has, you can see, a QRS and a T and a QRS and a T. You can even see the P wave here, P, QRS, T. And you see that that pattern continues, yet the device somehow doesn't see it. And it's calling this a pause of greater than 2,000 milliseconds. And so these need to be reviewed carefully by a human at this point. We don't have any, the algorithms within the device for reading these, including some AI algorithms, are becoming very good, but they're clearly not perfect. So they still need to be overread. This is, you start to see a pattern here. We see QRSs here. The patient may have shifted position. The QRSs are still there, and these march out with the QRSs. They're not P waves. And so this is another example of undersensing. This is a different patient. This loop recorder was implanted for a history of syncope, and I think the patient had it for quite a long time before anything happened. And then the patient had syncope, and then the loop recorder was interrogated, and this is what it showed. And so the patient is going along in sort of sinus rhythm or mild sinus bradycardia, and then all of a sudden is asystolic. And the asystole lasts for more than 10 seconds. And then down here you see an escape beat finally, and the patient survived, fortunately, and went on to get a pacemaker and never had any more syncope. So this turned out well for this patient. It was an appropriate use of the loop recorder. Here, the sort of fine fibrillatory noise that we can't really see here, but the device seems to be picking up, may have been seizure activity in a patient whose brain had just not been perfused for more than 10 seconds. I think this is my last loop recorder, loop recorder image. This was provided by a colleague at Northwestern who had a patient that was had some sort of supraventricular rhythm, either AFib or sinus rhythm with a lot of ectopy here, that then regularizes into what is a regular narrow complex tachycardia, likely an SVT here, if you can see my arrow. And then it breaks, and then there's a PVC, and it degenerates into something that looks like ventricular tachycardia or ventricular fibrillation. This patient survived and ultimately received a defibrillator, an implantable Cardioverter-Defibrillator, after this tracing was identified. So now we'll switch gears and talk about the future of ambulatory ECG monitoring, which, according to Tim Cook, the CEO of Apple, is this future is on your wrist. We'll talk about why this is the case, and it is due to some emerging technologies and also healthcare economics and changes in the economics of how we do things. This is an interesting picture from one of our conferences in 2005. You can see here in 2005 and then in 2013, by just over this 8-year period of time, everyone here at this session seems to have purchased a cell phone. And so although this slide is outdated now, I think it's still useful, because according to these data from 2017, there were 7.4 billion people in 2017, but there were 7.8 billion mobile accounts. So I am not sure why, but there were more mobile accounts than there were people as of 2017. And of those devices, more than half of them were smartphones. So it turns out that smartphone sorry about that. The smartphone-based AFib monitoring works pretty well. And the technique that we use is called photoplethysmography. It uses a downloadable application and hardware that's already present in a smartphone, which is the camera and the lamp. And according to this study here by Chang, the sensitivity in this study of 1,013 patients who had known AFib risk factors, the sensitivity and specificity were 93% and 98%. Another study showed a real world sensitivity of 71%, but there are some subsequent studies that show the real world sensitivity is probably higher than that. Another option that is very handy and I recommend for a lot of patients is this little device made by AliveCor. You can see it also right here. It's a little plastic plate with metal electrodes on there, and the patient puts his or her thumbs on these metal electrodes here. And it generates a single lead ECG, which is the equivalent of lead 1, the limb lead 1 on an ECG. And these used to be over $100. I noticed that at Walmart now, they can be purchased for $60. So most patients can afford this. And for your patient that has occasional palpitations, I think it's worth recommending something like this. It is FDA approved, and the patient can make a recording when he or she is having the symptoms, and it allows them to create a PDF very easily of whatever their rhythm tracing was, and they can send it to you or they can bring it to your office. This is a fancier version of the same thing, where not only does you have lead 1 by placing the thumbs on these electrodes, but there's a third electrode underneath this, and this woman is touching it to her leg, and it can generate now 6 leads of a 12-lead ECG. So it could potentially be used for looking at things like ST elevations and stuff, although it hasn't been FDA approved for that yet. Overreading on these things is critical. The patient will probably not know that this is artifact, but if you look at these QRSs and you march them out, you can see that they continue to march out here, and that there's a lot of noise in between there. And this is probably somebody that was shaking, or there's some other motion artifact here. So be prepared to see this when the patient brings his or her own tracings. There are also now many smartwatches that offer some form of heart rhythm monitoring. Most of these watches use photoplethysmography to indirectly monitor a patient's heart rhythm by measuring his or her pulse. But there are also at least 5 different smartwatch brands that offer a patient-triggered single lead ECG option, like the CardioMobile that I just showed you, that plate. As of this spring, the smartwatches that include single lead ECG recordings that are available are from Apple, Samsung, Fitbit, Withings, and Huawei, although Huawei is probably not available to us in the United States. They make one of these as well. And this slide is probably already outdated, even though I only made it a couple of months ago, because there are so many other options that are on the verge of coming to market. I want to point out that you should be aware that a lot of smartwatches strongly imply and falsely imply that their watches offer ECG monitoring, when in fact they only offer photoplethysmography. And that's worth mentioning, because although photoplethysmography, the light, is very good at detecting AFib, it's really bad at detecting PVCs. So it tends to not be sensitive for PVCs. And if a patient has symptomatic PVCs or some other ventricular arrhythmia, they need to have, at least as of today, one of these types of watches where they can actually record an ECG. Here's an example of a smartwatch using photoplethysmography to detect AFib. You can see that they were relatively normal until this point when they went into AFib. This is an Apple smartwatch that I'm showing you here. They have the intermittent patient-activated ECG recording. Since the watch is touching the patient's wrist, usually the patient's left wrist, the patient can then place his or her right finger onto the bezel, and that generates an ECG lead 1, and you can see that recording here. The quality of the recordings tends to be very good. It also performs intermittent photoplethysmography using the light on the back. These data are patient-facing, that is, they only go to the patient, which can be a blessing and a curse. The cost of a smartwatch that has both the ECG recording and the photoplethysmography is in the $300 to $500 range, plus a monthly subscription that's usually $10 a month. So while this is a lot cheaper overall than a loop recorder, for many patients this is too expensive. But still, the Cardia plate that I showed you that you can get from Walmart or Amazon.com for $60 one-time expense is affordable for most people. I'm just going to list some advantages and disadvantages of smartwatches here before we finish off. Advantages of smartwatch compared to, say, a loop recorder or other long-term ECG monitoring is that these are non-invasive, they're convenient, they're relatively inexpensive, and they'll probably become increasingly inexpensive. They're widely available throughout the world. They can be used for general screening, especially for AFib. They encourage the patient's lifestyle management and personalized medicine. They have the photoplethysmography recordings, which are intermittent but not continuous. The patients are responsible for their data, and I think in the future we'll see that these smartwatches will be applied to a wider group of medical conditions, not just AFib and palpitations. Disadvantages are that these have intermittent patient-activated ECG recordings, not continuous, like, say, a loop recorder. There are a number of electrical and motion artifacts, which I showed you an example of a few slides ago. The photoplethysmography often has a low sensitivity for PVCs. There's less rigorous validation for using the data from a smartwatch than there is from a traditional recorder like a Holter or event monitor or loop recorder. Even if the patient shows you data from their smartwatch, you may feel compelled to get a gold standard ECG confirmation of that and order the other test anyway. The patient may not know when to seek medical care. They may have a very abnormal rhythm and not do anything about it. There are obvious income and education disparities, and the cost to the patient, the watch, and the service plans exacerbates these. So comparing long-term cardiac monitoring, the traditional implantable loop recorder versus the smartwatch. The loop recorder is invasive, the smartwatch is non-invasive. The loop recorder offers continuous monitoring, the smartwatch intermittent monitoring. The loop recorder has an auto trigger and a patient trigger ECG recording. The smartwatch only has a patient triggered ECG recording, but it has some auto trigger photoplethysmography recordings. With the loop recorder, the data are physician facing. With a smartwatch, the data are patient facing. The loop recorder is ideal for diagnosing patients with cryptogenic stroke and infrequent syncope. The smartwatch, as of now, is ideal for diagnosing patients with palpitations and paroxysmal AFib. The loop recorder is better for a less motivated patient or a tech-averse patient. The smartwatch is better suited for a patient that's self-motivated and possibly tech-savvy. The economics of healthcare will impact us greatly on how we are monitoring our patients in the future. And so it's worth mentioning that the insurance coverage for implantable loop recorders is declining. Currently, in Iowa, it's usually only possible to get a loop recorder for cryptogenic stroke or recurrent syncope, and that's after 1 or 2 30-day event monitors. The reimbursement for placing in a loop recorder is also declining, which in a perfect world should not affect how they're used, but unfortunately, financial incentives significantly influence physicians' supply of health care. I provided a reference here. And sadly, but realistically, we don't do what we don't get paid for. In this slide, I want you to consider the market capitalization of a company like Medtronic, which is the major supplier of implantable loop recorders and pacemakers, to the market capitalization of Apple, which is a major supplier of smartwatches. When I made this slide, the market capitalization of Medtronic was about $160 billion. The market capitalization of Apple was over $2 trillion. So depending on the day, Apple is 12 to 15 times larger than Medtronic. And consider that in the competition for the long-term cardiac monitoring market, Apple benefits from an already established direct-to-consumer payment model. Tim Cook was interviewed in the February 10th, 2021 edition of Outside magazine. And during that interview, he provided a window into what's in Apple's future. But I think the most stunning quote from the article is this. He says, "I really believe that if you zoom out to the future and then look back and ask, what has Apple's greatest contribution been? It will be in the health and wellness area." So that was a surprise to me. Throughout this talk, I've referenced the recently published collaborative statement on M-Health and arrhythmia management, digital medical tools for heart rhythm professionals. Earlier this year, the International Society of Holter and Non-Invasive Electrocardiology, in collaboration with the Heart Rhythm Society, the European Heart Rhythm Association, and the Asia Pacific Heart Rhythm Society, published these guidelines on applying mobile health or M-Health technologies to our patients with arrhythmias. It's a 54-page document that actually seems like less than that. It has a lot of interesting diagrams. It was published in Cardiovascular Digital Health. It discusses these novel devices in our patients. And in addition to a discussion about the use of smartwatches, it also discusses other major M-Health technologies like handheld devices, wearable patches, and even biotextiles. And there's some other stuff that you may or may not have seen. So this is a new journal that's published by the Heart Rhythm Society, and it's available for free online. What questions can I answer?
Great, that was fantastic, Sam. I'm monitoring the chat. I don't see any questions typed in yet, so I'll go ahead and ask one while we give people a minute or two to type their questions. So, along with this explosion and people having, patient-facing or, ways to own their own equipment to record their heart rhythm. At the same time, patients have access to download things directly into their medical record. And the combination of the two can get kind of overwhelming sometimes, as patients, may download a lot of data. Do you have guidelines, or do you have what sort of things do you let your patients know with regard to what they should, I guess upload is the right term, what they should upload to their medical record, and how to kind of keep that to a manageable volume?
This is a great question, and something that I think we're all struggling with, including me. I have, it just takes one patient that is either very motivated or very neurotic to make your practice difficult. So I remind patients when I see them in clinic that I will be able to review their tracings when they come to clinic, and I encourage them to show them to me when they come to clinic. I try to set up an expectation where I'm not going to be looking through their medical chart every evening, and that primarily we'll be discussing these tracings when they're at clinic. Sometimes I still get tracings that are sent to me outside of that time, and as time allows, and depending on the patient, I may look at those and then get back to the patient. Some of that can be reimbursed, and a lot of it cannot. But these issues are being addressed by HRS and who are hopefully representing us well, and will make it possible that we're able to be reimbursed for the extra work of looking through all of this.
Okay, fantastic. I don't see any other questions typed in right now. So what I would direct people to do if they have a question and didn't get a chance to ask it, or come up with a question later, is either to send those to the event coordinators, or to your physician liaison for CME. And we will get those questions to Dr. Johnston to get his answers. And otherwise, I think we'll wrap it up for now. Thank you very much, Dr. Johnston. That was fantastic.
Thanks, Dr. Zingman. Thanks, everyone, for joining.